Hello everybody, this is Dr. Nadeem and we are with NEURO-PATH lectures, the Pursue series. As you are aware, all our lectures are available on YouTube. We also have a Telegram group. You can join the group to access all lecture related information. We have a Google Drive where all the PDF of lectures are available. We have a master integration key by which you can navigate between the PDF as well as the YouTube lectures. These are the disclaimers, and we are with phase 3, which is recorded pathology lectures. And this is Pursue 70, which is Neuropathology, Brain Infection Session 2. We are streaming from IPGMER, Kolkata. And to talk on today's topic, we have Dr. Shristi Butta, who is an MBBS Honors Gold Medalist, MD Pathology. She's the Demonstrator and the Oncopathology Unit, Department of Pathology, IPGMER, and SSKM Hospital, Kolkata, with 12 publications in national and international journals. Her special interest is neuropathology, molecular genetics, and hematopathology. With this, I would request Dr. Shristi Butta to start her talk on brain infection session 2. Over to you, ma'am. Thank you so much.
A very good morning. We are back again with our neuropathology lecture series, and this is brain infection part 2. We will be discussing about viral infections today. So before I start, I'd like to thank Nadeem sir for his path-breaking initiative of starting this Pursue lecture series for residents, particularly the junior and the senior residents. So let's start. So what do we plan to discuss today? We plan to discuss about the general principles of CNS viral infections with a particular focus on the pathogenesis and the spread of neurotropic viruses. We'll also be discussing about the viral inclusion bodies and Zanx Mirror preparation and analysis, Herpes simplex encephalitis and cytomegalovirus induced encephalitis, enteroviruses and arboviruses inducing encephalitis, and finally, the slow viruses with a particular emphasis on human immunodeficiency virus or HIV. So let's start. So now coming to the general principles of CNS viral infections. Now, virus-induced diseases of the central nervous system represent a significant burden to the human health worldwide. The complexity of these diseases is induced by the sheer number of different neurotropic viruses, the diverse route of CNS entry, viral tropism, and the immune system per se. Following any CNS infection, inflammation can arise in different anatomical sites, as we all know. That is, it can either be a meningitis or an encephalitis, or involving the spinal cord resulting in myelitis. Or for that matter, it can simultaneously involve multiple sites like the meninges and the brain, causing meningoencephalitis, or brain and spinal cord resulting in encephalomyelitis for that matter. Encephalitis is a clinical syndrome characterized by fever, altered consciousness, seizures, neurological deficits, and CSF pleocytosis. The cause of encephalitis is not known in about half of the cases. Among the known causes, about half are caused by viruses, and the most common is the herpes simplex virus. Herpes simplex virus type 1 is the one which is responsible for about more than 90% of the cases. HSV2 or herpes simplex virus 2 is primarily responsible for disseminated neonatal encephalitis, although rarely it can also involve the elderly and the immunocompromised individuals. So viruses enter the body via the respiratory system, particularly the mumps and the measles virus, or via the gastrointestinal tract like the enteroviruses, or for that matter by the inoculation of insect bites like the arthropod viruses, or from animal bites like the rabies virus. Most viruses reach the CNS via the bloodstream. Some viruses, including the herpes simplex virus, varicella zoster virus, and rabies virus for that matter, may also travel to the CNS along the nerves. So now coming to the pathogenesis. Viruses are obligate intracellular organisms. They use the cellular machinery of the host for their replication or damage and kills the cells they infect. Additional brain damage is caused by the release of potent cytokines like the TNF-alpha, interleukins, and interferons. So let's see how. As we can very well appreciate that this is an intact blood-brain barrier. This blood-brain barrier is disrupted by the infiltration of inflammatory cells, particularly the neutrophils and the monocytes. Okay, the acute inflammatory and neuroinflammatory responses to the CNS viral infection exerts both protective and injurious effects. So what are the protective effects? It blocks the viral replication, enhances non-lytic viral clearance, facilitates the adaptive immune response, and promotes pro-resolution of the cytokine production. The detrimental effects include impairment of the blood-brain barrier integrity, inducing microglial and astrocyte reactivity, formation of characteristic microglial nodules, and reactive astrocytes or gemistocytes for that matter, resulting in characteristic gliosis. It also drives the leukocyte infiltration and triggers inflammatory cytokine production. It disrupts the synaptic homeostasis, resulting in characteristic altered Caesar threshold and epileptogenesis. In addition, it also results in the characteristic oxidative stress and neuronal necrosis. Okay. So now coming to the histological aspect of the viral infection. Histologically, viral infections show characteristic inflammation and brain damage. As we have already discussed in the pathogenesis, the inflammation is characteristically neutrophils, but later on it is followed by a lymphoplasmacytic infiltrate with infiltration of macrophages. These cells infiltrate the arachnoid membrane and the brain diffusely, but are more concentrated around the blood vessels, resulting in a characteristic perivascular lymphoplasmacytic infiltrate. As seen in the figure alongside, there is also formation of a characteristic microglial nodule. Activation of the microglia, that is, the indigenous macrophages of the brain, causes these cells to proliferate diffusely and form small clusters called the microglial nodules, which are the histological clue to any viral infection. Tissue damage ranges from individual cell damage to diffuse brain necrosis involving large contiguous areas. Certain viruses cause intranuclear and cytoplasmic inclusions. These inclusions can either be eosinophilic or basophilic, or for that matter, amphophilic. These masses consist of packed viral particles and products of their replication. So as seen in the figure alongside, that this is a Herpes simplex virus inclusion, resulting in a characteristic multinucleation, molding and margination of the nuclear chromatin, resulting in a characteristic ground glass appearance. Inclusions can also be seen in cytomegalovirus, where it may be a single eosinophilic to basophilic intranuclear inclusion with a characteristic perinuclear halo. Some stippled cytoplasmic inclusions can also be appreciated in this diagram. Besides herpes and cytomegalovirus, varicella zoster, papovavirus, measles, etc. can also result in viral inclusions. When the inflammatory and immune reactions of viral encephalitis subside, the lesions heal with a characteristic formation of a glial scar. However, lost neurons do not regenerate. So, in the aftermath of viral infections, patients are often left with a severe permanent neurological deficit. So now coming to the viral inclusion bodies. These viral inclusion bodies can either be intracytoplasmic or intranuclear. Intracytoplasmic viral inclusion bodies include the Henderson-Peterson body of molluscum contagiosum, Nacre bodies of rabies, Guarneri bodies of smallpox, etc. The intranuclear inclusions can either be Cowdrey type A or Cowdrey type B. Cowdrey type A includes the varicella zoster, herpes simplex, and yellow fever, whereas Cowdrey type B can either be eosinophilic or basophilic and can be those involving the poliovirus or the adenovirus and cytomegaloviruses. So this diagram shows you the characteristic Cowdrey type A and Cowdrey type B inclusion bodies, right? These Cowdrey bodies are eosinophilic or basophilic neuronal inclusions, and these are characteristically intranuclear. They are composed of nucleic acids and proteins. This cytopathic change is considered a characteristic hallmark of the viral infections. They are named after Edmund Cowdrey. Inclusions appear as homogeneous, eosinophilic or basophilic to amphophilic inclusions, okay, as seen in Cowdrey type B here, okay, or it can be an eosinophilic inclusion with a characteristic perinuclear halo as seen in Cowdrey type A inclusions. So now coming to Zanx Mirror. Now Zanx Mirror, what is it? It is a simple test and a cheap test that relies on viewing and interpretation of single cells, that is cytology of the cells. But where do we require this? We require this when we are reporting a case of blisters, say for example in case of a Herpes Simplex virus, which characteristically causes a mucocutaneous infection of the skin, and followed by that it causes a dissemination to the CNS resulting in Herpes Simplex Encephalitis. Zanx Mirror has following benefits. It is an inexpensive test and uses minimal techniques. It causes minimal discomfort to the patient. It is quick and allows for rapid diagnosis, which yields initiation of treatment at an early stage. So now how is the Zanx Mirror prepared? It is prepared using a blunt scalpel blade by gently de-roofing the lesion or the blister. The scrape is thereafter smeared onto a clean microscopic slide, air dried and fixed in a fixative. Okay. Now what happens in the laboratory then? We use a gene sustain, okay, which is poured onto the slide, and after 15 minutes the slide is washed with sterile water. Cell cytoplasm stains blue, as you can see in the figure alongside, okay, and the nuclei characteristically stains deep blue to purple. Toluidine blue is another stain which can replace gene sustain, as it is rather quick and requires merely 60 seconds. Now, how do we classify these viruses according to the site of involvement? Now, the virus can either affect the meninges, okay, or for that matter, it can involve the cortical neurons or the oligodendrocytes, or for that matter, microglia, thalamus, hippocampus, brainstem, cerebellum, and ependyma. So, depending on the site of involvement, the viruses can be classified. If we consider the meninges, it must be noted that the meninges is characteristically affected by human enterovirus, human immunodeficiency virus, Japanese encephalitis virus, mumps and Nipah virus, whereas the cortical neurons are affected by the alpha virus, the Bunia virus, Herpes simplex virus, and even the Japanese encephalitis virus. We must also remember that the West Nile virus also affects the cortical neurons. The oligodendrocytes, on the other hand, are affected by the JC virus, that is the John Cunningham virus. Okay. The microglia, on the other hand, is affected by the human immunodeficiency virus, as we all know. The thalamus and the hippocampus are affected by the human enteroviruses, the rabies virus, and the West Nile virus. The cerebellum is also affected by the West Nile virus and the human enterovirus, whereas the brain stem is characteristically affected by the poliovirus and the human enteroviruses, as well as the rabies virus. What about the ependyma? The ependyma, or the choroid plexus, is affected by the cytomegalovirus and the human enteroviruses, as well as the mumps virus. So moving on, if we find the spinal cord, we find that the motor neurons of the spinal cord are affected by the human enterovirus, Japanese encephalitis virus, poliovirus, rabies virus, and the West Nile virus. So depending on the site of involvement, these viruses have been divided. So now coming to the CNS invasion by the viruses. How do the viruses invade different structures of the CNS? First of all, it must be noted that there is one important route of entry of any infection into the brain, that is via the blood. Viruses can also be inhaled like measles and mumps, or ingested like the enterovirus, or for that matter, arboviruses can enter the skin via an insect bite. It can thereafter migrate to the draining lymph nodes. Only it must be noted that secondary lymphoid tissues can be affected by viruses that are often shed from the bloodstream, resulting in a characteristic systemic infection. So now the delicate CNS parenchyma is protected from harmful substances in the blood by an elaborate barrier network, as we can see alongside here. Okay, and this forms the characteristic blood-brain barrier, as you can very well make out. So some viruses can directly infect this vascular endothelial cell, and that allows the viruses to traverse this blood-brain barrier, and there is a transcellular migration, okay, via the tight junctions, or for that matter, there is an additional route. The infected hematopoietic cells can traverse this blood-brain barrier and can act as Trojan horses. Okay, so these Trojan horses allow the transport of the virus into the CNS parenchyma via the blood supply. Okay, so this is the Trojan horse mechanism. Besides this, it must also be noted that the viruses can also travel the CNS, okay, via the nasal, oral, or axonal transmissions via the olfactory, lingual, or the vagus nerves. So yes, a second major route of CNS entry after the blood is the peripheral nerves. So while rabies virus initially infects myocytes after a bite from an infected animal, polioviruses infect the mucosal epithelial cells after injection, and they both use the peripheral motor neurons, as we have already discussed, to make their way into the CNS. Herpes simplex virus 1 initially infects the keratinocytes before migrating to the peripheral sensory neurons. So, herpes simplex virus 1 has been proposed to reach the CNS via the olfactory sensory neurons, whose dendrites are directly exposed to the airways in the nose. Nipah virus, influenza virus, and rabies virus have also been proposed to enter the CNS via the olfactory nerves. It is important to note, however, that while some viruses have a preference for the hematogenous or peripheral nerve route to CNS entry, other viruses are able to take advantage of both the routes, that is, both blood or hematogenous and peripheral nerve route. Once viruses reach the CNS, viral tropism and ensuing immune response combine to shape the resulting disease, as we have already discussed in the pathogenesis section. Viruses that remain within cells of the meninges or ventricular lining often result in characteristic meningitis, whereas those infecting the CNS parenchyma can result in a characteristic meningoencephalitis, encephalitis, or myelitis. Now, if we see this diagram, what do we see? We see that the neurotropic viruses, okay, which may be herpes simplex virus, cytomegalovirus, rabies virus, poliovirus, etc., can basically affect the CNS, okay, or through the periphery. They can also cause activation of leukocytes. These leukocytes, on being activated, produce characteristic inflammatory cytokines which disrupt the blood-brain barrier, and there is a characteristic extravasation of albumin, immunoglobulin G, and other immune cells, particularly the monocytes, T cells, neutrophils, etc., and that characteristically causes these astrocytes to undergo ionic imbalance, as a result of which there is decreased glutamate uptake and increased glutamate release. Now, glutamate is an excitatory neurotransmitter, and this results in characteristic neurotoxicity, as we had discussed in our first class. In addition, there is also an increase in TGF-beta and other inflammatory cytokines. Besides this, the neurons undergo a characteristic alteration of the glutamate GABA receptors, and there is a characteristic neurogenesis, sprouting and angiogenesis which develops. Altered synaptic transmission and neuronal hyperexcitability due to glutamate results in characteristic seizures, epileptogenesis, and cell death. In addition, it must also be noted that infection of the CNS can result in a characteristic formation of a microglial nodule and reactive astrocytes, as well as cause an oxidative damage to the neurons, resulting in a characteristic neuronal necrosis. Now moving on to herpes simplex encephalitis. Herpes simplex encephalitis, basically you must note, is caused by herpes simplex virus type 1. This is transmitted via the saliva, right? The initial infection is a stomatitis, and following this the virus remains latent in the trigeminal ganglion. From this location the reactivated virus can spread either to the skin along the branches of the trigeminal nerve, causing soring on the lips. Yes, as we all know, it is called as herpes labialis, or to the brain, infecting the meninges. The typical clinical feature is a prodromal flu-like illness like fever and headache, and manifests as a superimposed behavioral change with seizures and focal neurological signs, as well as cognitive impairment. From the meninges, the virus extends to the adjacent brain, where it affects the temporal and the inferior frontal lobes. Okay, it must be noted that the herpes simplex virus encephalitis is a severe necrotizing viral infection that predominantly affects the medial, temporal, and the frontal lobes of the brain. It characteristically results in fever, confusion, coma, and seizures. In addition, involvement of the frontal and temporal lobes result in characteristic bizarre behavior, personality changes, anosmia, and gustatory hallucinations. Survivors may have a Korsakoff's amnesia because of the bilateral damage of the hippocampus, dementia, and seizures. So the figure here shows a characteristic autopsy finding in a patient affected with herpes simplex virus. This shows a characteristic diffuse softening and edema of the brain parenchyma with hemorrhagic necrosis in the inferior frontal and temporal lobes of the brain. Microscopically, it is characterized by a characteristic perivascular mononuclear inflammatory infiltrate. There is also formation of a characteristic microglial nodule. Without treatment, extensive necrosis, macrophage activation, and neovascularization develops, which results in a characteristic brain atrophy and gliosis in the end stage. Herpes simplex virus type 2 also causes a similar disease and is a frequent cause of aseptic meningitis. Both type 1 and type 2 affect immunocompetent and suppressed individuals. However, it must be noted that HSV type 1 mainly affects the immunocompetent patients, whereas HSV 2 affects the immunosuppressed individuals. Other changes associated with herpes simplex virus include a characteristic multinucleation, as you can make out here, and nuclear balloon degeneration with characteristic ground glass chromatin. As we can also see and make out, there are some nuclear inclusions that are also seen. Okay, so this is the histopathological picture, which shows a characteristic multinucleation and nuclear molding appreciated in case of herpes simplex virus, and this is the characteristic Zanx Mirror showing a multinucleated giant cell in case of a herpes simplex virus infection. Now coming to the CSF examination, the CSF shows pleocytosis. Now pleocytosis may be early neutrophilic or late lymphocytic. There is elevated protein, and depending on the degree of brain necrosis, the protein elevation is affected. Glucose, however, is normal, and HSV is typically hard to isolate from the cerebrospinal fluid. So in the past, the diagnosis of HSV encephalitis required brain biopsy with fluorescent antibody staining using anti-HSV antibodies. microscopic study and viral culture. Now, however, we can do a CSF PCR to detect HSV DNA. Now coming to neonatal HSV encephalitis. Now neonatal herpes simplex virus encephalitis is basically caused by HSV type 2. HSV1 is most commonly acquired during vaginal delivery by contact. Most infections occur in mothers who are asymptomatic. Cesarean delivery before rupture of membrane prevents these infections. In a few cases, however, herpes simplex virus can traverse across the placenta. Untreated neonatal herpes simplex virus infection usually disseminates and involves the brain. There is a generalized infection affecting the skin, eyes, liver, adrenal glands, and other organs, resulting in a characteristic neonatal sepsis. Encephalitis develops around 1 to 2 weeks after birth. A few cases of neonatal herpes simplex virus encephalitis are mild, but most cases are devastating, with a diffuse necrotizing pathology characteristically involving the frontal and the temporal lobes. In time, the lesions evolve into a cystic encephalomalacia and microcephaly, as we have discussed. The pictures of cystic encephalomalacia and microcephaly have been discussed in the earlier classes. So now coming to cytomegalovirus induced encephalitis, or the CMV encephalitis, which is rare in adults, okay, and usually happens in immunocompromised individuals. It affects the neurons and glial cells that enlarge and develop characteristic cytoplasmic and intranuclear inclusions. Microglial nodules and inflammatory infiltrate, which is particularly rich in lymphocytes and macrophages, infiltrates the lesions. The lesions become heavily necrotic and characteristically have a predilection for the walls of the ventricles. So in this figure shown alongside, you can appreciate the intranuclear and the intracytoplasmic inclusions with a characteristic perinuclear halo that is appreciated in case of a cytomegalovirus induced encephalitis. So now it must be noted that a pregnant mother who carries the cytomegalovirus may transmit the virus to the fetus, causing a characteristic generalized fetal CMV infection. So this infection may develop at any stage during the pregnancy and may continue even after the delivery. So prenatal CMV infection often causes necrosis of the brain tissue, especially of the walls of the lateral ventricles. Necrotic areas often calcify. So calcification may be captured on imaging. In addition, infection before mid-gestation may derange the process of neuronal migration, causing a characteristic microcephaly and cortical dysplasia. Note, cortical dysplasias often result in characteristic epilepsy. In some cases, fetal CMV infection destroys larger parts of the brain, causing a characteristic porencephaly and schizencephaly. These lesions are thought to be caused by ischemia induced by the infection. Okay, so this is a characteristic microscopic picture of a cytomegalovirus with a characteristic intranuclear inclusion and a lymphoplasmacytic infiltrate noted in the background. Now, the sites of predilection may infect all levels of the central nervous system, but classically CMV often causes a damage to the subependymal region of the cerebrum, cerebellum, and brainstem. Note the subependymal regions of the cerebrum, cerebellum, and the brainstem. Spinal cord and nerve root infection is also common in immunocompromised individuals. So now coming to the autopsy findings. At autopsy, we see that the coronal section of the thalamic nuclei demonstrates a characteristic necrotizing ependymitis. Okay, with a fibrinous exudate. In addition, we find that there is an aqueductal stenosis, particularly arising from the inflammatory necrosis within the ependymal lining, resulting in characteristic hydrocephalus. Okay. Now coming to the enterovirus infection. Now enteroviruses are small RNA viruses that are transmitted from human to human via the fecal-oral route or the respiratory route. Humans are the only hosts. There are more than 100 serotypes of the enteroviruses. Neonatal enterovirus infection usually is transmitted from the mother and can cause fatal disseminated diseases involving the brain, heart, liver, lungs, and other organs. In older children and adults, enterovirus infection tends to be more limited and causes mucocutaneous eruptions, conjunctivitis, respiratory illness, and myocarditis. Poliovirus, it must be noted, is an enterovirus, and polio as such means grey in Greek. Okay, so that is why the poliovirus characteristically affects the grey matter. Enlarged motor neurons are characteristically but not pathognomically affected by the poliovirus. In the muscle fibers that are affected by acute poliomyelitis, the original innervating neurons are destroyed, and neighboring neurons reattempt to innervate the denervated tissue. This leaves the surrounding motor units innervating more muscle fibers than intended, and enlargement of the affected neuron and is suspected to be a part of the fatigue associated with poliomyelitis. Now, polio has been eradicated from the world, as we all know, and there are some other non-polio enterovirus subtypes or serotypes for that matter, which cause a wide spectrum of neurological diseases. The most common and benign form of CNS involvement is an aseptic meningitis, and less frequently enteroviruses can cause paralytic diseases, transverse myelitis, Guillain-Barré syndrome, cranial neuropathy, and brainstem encephalitis. One of the most dangerous enterovirus serotypes is the EVA71, which is also one of the agents responsible for the hand, foot, and mouth disease. Enterovirus-induced encephalitis has a predilection for the grey matter, as we have already discussed. That is, the polio virus, or the polio in Greek, means grey. So the areas that are most severely affected in polio are the grey matter of the spinal cord and the grey matter of the brain stem, resulting in the characteristic cranial neuropathies. Poliomyelitis, as we all know, affects the motor cortex. However, neonatal enterovirus encephalitis is more disseminated and affects not only the grey matter but also the white matter. The pathology consists of a characteristic perivascular and meningeal inflammation, which is neutrophilic in the early stage, and followed by mononuclear infiltration in the later stages. There is also formation of a characteristic microglial nodule. Now, the most common cause of viral meningoencephalitis in young is the Piccolna virus. It is a new virus, that is the human paracovirus 3. Initially classified as an enterovirus, is now reclassified as a separate genus. It causes a characteristic cyclic outbreak and nosocomial infections every 2 to 3 years with high fever, irritability, and seizures. There is no CSF pleocytosis, and PCR is usually required for the diagnosis. The virus causes a characteristic necrotic white matter lesion, which is indistinguishable from a periventricular leukomalacia, which has been discussed in the earlier class. Arthropod bone viruses, or the arboviruses, are a small group of RNA viruses that are transmitted to humans via the mosquito or insect bites. As we know, the mosquito acquires the virus by biting infected birds, rodents, or horses. Most arbovirus infections are asymptomatic, but a minority can cause CNS infections, particularly the meningitis and severe or fatal encephalitis. So the most important arboviruses are the West Nile virus and the La Crosse virus. And in recent years, even the Zika virus has emerged as an important cause of prenatal infections in South and Central America. Now, West Nile virus encephalitis is the most common arbovirus encephalitis in adults. Elderly patients are affected and present with fever followed by an altered mental status and even progression to coma. So some patients with West Nile virus encephalitis have a severe asymmetric areflexive weakness and a complete flaccid paralysis. Other neurological manifestations include ataxia, optic neuritis, and seizures. The mortality rate in patients with encephalitis and muscle weakness is high, and survivors have a residual neurological deficit, including fatigue, weakness, memory loss, and depression. So what do we see here? We see the neuropathological examination, which shows a characteristic perivascular inflammatory infiltrate as shown in the inbox here. Okay, there is formation of a characteristic microglial nodule, okay, which is quite ill-defined here. Okay, and in addition, the background shows gliosis. What else can you appreciate? Yes, we can appreciate the characteristic neuronal necrosis and formation of red neurons. So now coming to La Crosse encephalitis. La Crosse encephalitis is the most common arboviral disease in children. It occurs during the summer and presents with fever, headache, vomiting, seizures, and disorientation. Hyponatremia and cerebral edema with herniation may develop. The CSF shows a characteristic mononuclear pleocytosis with a normal protein and glucose level. On microscopic examination, as seen in the figure alongside here, the brain shows a characteristic perivascular mononuclear cell infiltration with formation of a characteristic microglial nodule. Now coming to Zika virus. Now Zika virus is an RNA flavivirus which is transmitted by Aedes aegypti. Okay. Most patients are asymptomatic, but about 20% present with non-specific symptoms that resemble dengue, like fever, headache, myalgia, arthralgia, maculopapular rashes. Rare infections can also cause Guillain-Barré syndrome. When Zika infection occurs during pregnancy, the virus crosses the placenta and can affect the fetal brain, causing devastating effects. So babies born to Zika virus infected mothers have a characteristic microcephaly. So the autopsy finding shows characteristic microcephaly, brain atrophy, enlarged ventricles, okay, and characteristically abnormalities in the cortical development. There is calcification noted in the cortex and subcortical white matter and in the deep nuclei. Abnormalities of the brainstem and cerebellum and abnormalities of the corpus callosum and microphthalmia are also noted. Now, what is very important here is flavivirus NS1. Now, this is a multifaceted enigmatic viral protein. NS1 is highly conserved non-structural protein among the flavivirus group. The intracellular dimer form of NS1 plays a role in genome replication, whereas the secreted hexamer plays a role in immune evasion. The secreted NS1 has been identified as a potential diagnostic marker in the early detection of infections caused by flavivirus. In addition, the diagnostic marker, the importance of NS1 has been reported in the development of therapeutics. So NS1-based vaccines are at various stages of development. So from a pathologist's perspective, what is the role of this NS1? We now have an anti-flavivirus NS1-IHC that is available that helps in highlighting these flaviviruses which cannot be readily appreciated on any CNS microscopic section. So using an anti-flavivirus NS1-IHC helps us to identify these flaviviruses. Now, coming to slow viruses. Now, slow virus is a virus or a virus-like agent that, like a prion for that matter, okay, which causes a slow virus disease. A slow virus is a viral disease, okay, that has an extended period of latency. It follows a slow and progressive course spanning for months to even years. Examples of slow viruses can be HIV, or AIDS, which is caused by the HIV or the human immunodeficiency virus. A subacute sclerosing panencephalitis, which is caused by the measles virus, and there are other paramyxoviruses besides the measles virus which are also called as the slow viruses, and we also have the human respiratory syncytial viruses. So if we classify the slow viruses, how do we classify it? We classify it in the following manner. We have the JC virus, okay, that is the human polyoma virus 2, which belongs to the polyoma virus family and causes a characteristic progressive multifocal leukoencephalopathy. The BK virus, which causes BK nephropathy and bladder cancer, also belongs to the polyoma virus group. The measles virus belongs to the paramyxoviruses and causes a characteristic subacute sclerosing panencephalitis. Rubella virus belongs to the Togaviridae family and causes a progressive rubella panencephalitis. Rabies virus belongs to the Rhabdoviridae and causes characteristic rabies. Human papilloma infection is caused by the papilloma virus, and that causes cancers of the cervix, oropharynx, vulva, and anus, penis, vagina, or rectum. In addition, there is also a human immunodeficiency virus which belongs to this slow virus family. So why slow? This is because they cause an asymptomatic primary infection. They have a very long incubation period. They follow a slow and relentless course and progressively leads to death. It tends to have a genetic predisposition and often re-emerge from latency if the host becomes immunocompromised. Additionally, the immune system seems to play a limited role or no role at all for many of these viruses. This may be due to the slow replication rates some of these agents exhibit. Pre-existing immunosuppression is often required, especially in cases of HIV, JC virus, and BK virus. Now coming to HIV or human immunodeficiency virus. Now this virus selectively destroys the CD4 lymphocytes and causes immunodeficiency. Consequently, AIDS patients are susceptible to opportunistic infections like CNS toxoplasmosis, cryptococcosis, and mycosis, which we've already discussed in our last class, and CMV encephalitis, as we have discussed today. AIDS patients develop cerebral and other extranodal lymphomas, particularly the B-cell lymphomas or DLBCLs, due to the loss of surveillance function of the CD4 T cells. HIV also infects the central nervous system directly, causing aseptic meningitis, encephalitis, leukoencephalopathy, myelopathy, neuropathy, and myopathy. The most common of these direct effects include the HIV encephalitis, which causes a progressive memory loss, intellectual disorientation, behavioral changes, and motor deficits. So what do we see in the neuropathology of it? Okay, that is, histologically, we see a characteristic infiltration by these multinucleated giant cells, which are the hallmarks of HIV encephalitis. HIV encephalitis is characterized by diffuse myelin damage, neuronal loss, vascular damage, and formation of a microglial nodule and lymphocytic infiltrate. But however, it must be noted that the lymphocytic infiltrate is particularly scant, and there is characteristic large microglial nodules. HIV enveloped glycoproteins cause the membranes of the HIV infected macrophages to fuse. So these macrophages characteristically fuse and form the characteristic hallmarks of HIV encephalitis, that is the multinucleated giant cells. The inflammatory reaction to HIV encephalitis is mild, as we have already discussed, compared to other CNS infections. Okay, because the patients are characteristically immunodeficient. HIV is carried to the brain by the infected CD4 lymphocytes and perivascular monocytes. Microglial cells pick up the viral particles through the receptor-mediated endocytosis and acquire the virus by phagocytosing it. The only cells that harbor the HIV in the brain are the perivascular monocytes and the microglia, right? Or the macrophages for that matter. HIV can be transmitted from the infected mother to the fetus, resulting in congenital HIV infection. The lesions of the congenital HIV infections particularly result in microcephaly. And one additional distinctive feature of a congenital AIDS is basal ganglia calcification. So microcephaly with basal ganglia calcification is a characteristic hallmark of congenital AIDS. There is no productive infection of either the neurons or the glial cells. The brain damage is not due to the direct effect of HIV or either neurons or oligodendroglia, and neuronal dysfunction does not correlate with the viral load. Brain damage is particularly caused by the cytokines like the TNF or the neurotoxins like the glutamate and nitric oxide, which are produced by the activated monocytes and microglial cells. HIV enveloped glycoprotein, that is the GP120, also activates the NMDA receptors and causes characteristic oxidative stress and neurotoxic effects, resulting in neuronal necrosis and hypoxic neurons, or for that matter, the red neurons, as we had discussed. The pathology of HIV myelopathy resembles subacute combined degeneration. This suggests that metabolic changes induced by HIV may contribute to the damage of the myelin as well. So now coming to immune reconstitution inflammatory syndrome. Restoration of the immune system of HIV patients using antiretroviral therapy often leads to a new or exacerbated inflammation, which is called as IRIS. It is a state of dysregulated hyperinflammatory response against opportunistic infections that occurs in the first 6 months of treatment of HIV or AIDS patients. IRIS is a potential complication of HAART therapy, that is the highly active antiretroviral therapy, and was first reported in early 1990s. However, it must be noted that it only infrequently presents with neurological symptoms. So that is why we are just briefly touching on this. So now, what do we conclude from this session today? Great strides have been made to identify viruses that infect the CNS and mechanisms that use to cause these viral diseases. Despite the diversity of the viruses that invade the CNS, that is the neurotropic viruses, many infections induce common pathogenic cascades, such as the breakdown of the CNS barrier, release of potentially detrimental mediators like the TNF-alpha interferons, reactive oxygen species, and glutamate that often result in a characteristic neurotoxicity and hypoxia. These universal mediators could therefore serve as therapeutic targets to lessen the pathogenesis associated with different CNS viral infections. The interferon 1 pathway, for example, plays an important role in the CNS defense against most viral infections, and modulation of this pathway might provide a therapeutic means to control the magnitude of CNS inflammatory responses. Viruses are particularly good at bringing their genomes into a variety of cells. Therefore, beneficial genes can be engineered into the viruses, like the adenovirus-associated vaccines. These replication incompetent vectors can infect neurons with minimal complications and lead to long-lasting transgene expression as well. Therefore, another potential role of these viruses is in the treatment of brain cancer, like the glioblastomas. Replication competent viruses such as vesicular stomatitis virus, myxoma, and herpes virus are being generated to target, infect, and kill glioblastoma cell lines. So eventually, I'd just like to end today by saying that in this era of artificial intelligence and digital pathology, we all need to work smart and not too hard, you see. Thank you so much and goodbye, only till next time, where we will be discussing prions and brain infections. Thank you.